does a patient present? For example, have you had access to what when they, had shown up?
Yeah.
What are the options that you would have offered at that point in time?
Yeah. I'll start saying that reconstructive surgery or a reconstructive surgeon is part of the multidisciplinary team. So a decision to plan management of breast cancer is made in that team. And once you've decided the way to go, maybe for Mwende's case, you would have done what is called oncoplastic surgery. That means you use plastic surgery techniques to get out the cancer, but preserve, do breast conserving surgery. And then with that, for your case, you didn't need radiotherapy or just on hormonal treatments, you are actually a perfect candidate for that. So we'd have a discussion with the breast surgeon, Dr. Mutebi, discuss on, depending on now your age, you're 23, you have no comorbidities, you can withstand reconstructive surgery, then we'll have offered you an oncoplastic surgery. But I'll just want to start from the top and just define what is breast reconstruction after mastectomy. So these are procedures that we do to actually rebuild a breast that has been lost or been forced to be removed due to breast cancer or other illnesses. And this can be done either immediately during the resection or during mastectomy, or delayed at a later stage, maybe after treatment of either chemotherapy or radiotherapy or combination. And there are factors that will determine whether you're going to do your immediate reconstruction or a delayed reconstruction. For example, what Dr. Ome said, there are different types of cancer. If you have an inflammatory breast cancer, which maybe has affected your skin, then you will not do an immediate reconstruction. But you have early disease, an isolated lump, you are no comorbidities, don't have cardiac heart disease, or diabetics, and we'll do an immediate reconstruction. And for you to do reconstruction, you can either use your own tissue, what we call autologous reconstruction, or artificial implants, which can be either saline implants or silicone. Most commonly we use silicone implants. If you opt to do silicone implants, then we have to do either staged or immediate. Staged meaning if you do resection and then you have to go for chemotherapy, your own tissue would also be affected by the radiation, sorry, not chemoradiation. So we'd opt to have an implant, because an implant is going to be resilient to your chemoradiation. Other factors is your patient choice. I know breast cancer is overwhelming, the diagnosis, the treatment. So majority of patients at that stage do not want to decide, or they're not in a frame of mind really to decide what reconstructive option they do want. So you'd find a patient will go through the treatment through radiation, chemotherapy, then 2 years, 3 years down the line, then they'd come for the breast reconstruction. And at that point, what will be available to you would be either what we call flaps. That means we take tissue from different parts of your body. We usually take tissue from either your tummy, your back, as part of your gluteus. And this tissue is transferred either as a free tissue, what we call free tissue transplant. Basically, you take a part of your flesh from one part, skin, fat, and sometimes muscle, to reconstruct the breast mound and reattach your vessels. Or you rotate tissue from your back, place it, shape it, and then put it on the area of mastectomy to give you a breast. And depending on the type of mastectomy that you had, either nipple sparing or a nipple sparing mastectomy, if you preserved your nipple during surgery, then it makes it easy. So you just have to replace the volume. But if the type of breast cancer necessitated removal of your nipple, then it means after you've reconstructed your breast, you have to do what we call nipple areolar reconstruction, reconstructive surgeries. Now, what will determine, let's say, whether you're going to do a simple, let's say, a pedicle or just moving tissue, or a free. If you had a previous surgery, for example, if you had a C-section, you had a tummy tuck, you had any other abdominal surgery, it will be very difficult for us to get tissue around your tummy, because that's the commonest area for us to get free tissue to transfer. So for that, then we have to either go to the back or use any other free tissue. Then the other part is your patient choice and education, and this is where we have a really big problem in terms of awareness, because we made good progress in terms of educating people on breast cancer and treatment, but we not offer breast reconstructive as an option, and not only to the public, but also even healthcare providers. I think we have to do more in terms of offering reconstructive option, because people who have successfully survived breast cancer, and they have lost their breast, they always have that reminder. They must have maybe a bra, some padding, to feel that their body image is still there, or still intact. So my plea is that we should offer breast reconstruction, especially as we plan on breast treatment, especially for early disease. Because for me, I'd say that in conclusion, breast reconstruction is a Bill of Rights issue, because you have to give the highest quality of care that you can give, and breast reconstruction is available. Thank you.
Great, thank you. I just wanted to. I hope you can all hear me. Okay. So, my question is, does insurance cover this reconstructive surgery? Because it is a medical surgery as opposed to purely cosmetic. And then secondly, how much would it cost to reconstruct a breast?
Dr. Mtibi, you want to take that?
I think that's one of the challenges and really one of the areas for advocacy, because just to chime in, breast cancer surgery has the highest psychological fallout, just in terms of body image, and but I think one of the biggest challenges that we've had, and one of the areas that we're really pushing from the surgical advocacy standpoint, is the understanding around reconstruction, because most people or most care providers equate reconstruction with cosmetic procedures, but nobody wakes up and says, this is a good day to lose my breast or lose my arm. If you offer reconstruction for all these, how is the breast any different? So it's really educating all our healthcare providers, whether in the public or private sector, to really support our ladies. I think the other aspect that I just wanted to mention as well is that breast cancer doesn't automatically equal mastectomy, as Dr. Ari was saying. It's a very nuanced discussion, depending if you have a single tumor, small tumor in an isolated area, you can do what they call breast conservation surgery, where you remove just that area, and you can do what Dr. Ari was calling oncoplastic surgery, which is a balance between, it's always about oncological safety. Can you get out the tumor safely? You take it out, send it to Dr. Owame to look at the margins, make sure the cancer is out, and then you can do different maneuvers to reconstruct the breast and make it look pretty, but you're not necessarily having the entire breast removed. Or depending, you can still have a super early tumor, but it's in multiple areas. So in that case, it doesn't make sense to go and just take out one area. You need to remove everything. And in those situations is when you can actually do a mastectomy plus an immediate reconstruction and stuff. But yeah, those are the challenges that I think we really need. I think everyone in the room in our different capacities really needs to spread the word around. Reconstruction is an essential continuum of care. It's still part of the care, and just I'm going to go off on a bit of a tangent. Reconstruction, and again, I'm happy that we're now starting to recognize the importance of the mental and psychological aspects of care, because really the cancer diagnosis is, we all deal, everyone deals with it differently, but it's, you're almost going through the stages of grief, because you're, grieving your old life and, sort of building back better and moving on, but it's still an emotionally distressing time. And we would routinely recommend, and most multidisciplinary teams have psychologists as part of the continuum of care, but sometimes the cost is very prohibitive. And when you try and get, the costings and things, patients actually say, Dr. let me I'll go for the counseling later, but really it should be an integral part. So if we're able to bring up all these supportive aspects of care, whether it's the reconstruction, whether it's psychological support, whether it's nutrition and education, I think we will have much better outcomes. And even when you're done with the initial treatments, the survivorship aspects, what are the concerns that are required? I think that's going to be really critical in terms of improving our overall outcomes and quality of life for our patients.
And maybe just to chime in, I think I'll pick from what Dr. Mtebia said, we should be focusing on outcomes. And I think and I like NHIF is really looking into outcomes as opposed to just a cost of that surgery, so that we cover the entire spectrum of a disease. And most insurance do not cover reconstruction because it's deemed to be cosmetic. But I think there's nothing cosmetic about you getting back a part of your body that you've lost through disease. And the cost ranges somewhere between $500,000 to over $1 million, depending on the choice and the multiple procedure. For example, if you're doing just breast mount reconstruction, then you go a nipple and dural reconstruction, that will increase the cost. And if you have to do, let's say, free tissue transfer, that is a bit more technical, will take more theater time, more intense monitoring for it to take. So really, it's an expensive affair, but it's worth it because it's part of the entire spectrum of outcome.
Great, thank you so much, Dr. Jojo. Thank you to all of our panelists as well. I would like to say thank you so much for your participation. And you may now take your seats, have a refreshment, everyone except Wande, because we still have one final thing that we need to discuss. So please carry on. Now,